Get started with noon conference today. We're going to do another one of our case presentations, and this one's going to be predominantly a diagnosis and a touch of management as kind of the flavor for how most of our cases go. So we'll go ahead and get started. So Danny's going to be recording it. He was just going to keep tabs on it. So our patient is coming in with a chief complaint of shortness of breath. So she's a 35-year-old female coming in with shortness of breath after presenting to her PCP. Apparently she comes to her PCP because she's been having a productive cough, shortness of breath, measured her fever up to 101.8, as well as having some chest pain, and but no sick contact. Said that she actually has been on oxygen for the past month because she had a recent bout of pneumonia and has required up to 2 liters of oxygen since then. What else would you guys want to know for her at this moment? Coming in, shortness of breath, cough, fevers, recent pneumonia.
So with her bout of pneumonia, was she like getting better? And now it's getting worse again? Has she stayed stably short of breath?
Yeah, good question. So she's kind of been stable where she's at. Hasn't really gotten worse, hasn't gotten much better, just kind of stable at that 2 liters. Feels pretty crappy since then.
This has all been going on for a month.
Yes, yeah.
How was she diagnosed with this pneumonia? Is it like WebMD?
Great question. I know, as many of us know, every patient has had a bout of pneumonia, even though probably only like 1% of them actually have had pneumonia. So she actually was in the hospital admitted for hypoxic respiratory failure, was diagnosed with multifocal pneumonia, and was treated with cap coverage. Has she been tested for COVID? So this is pre-COVID era.
So you're saying no?
She could have been patient zero. Now, 2 years ago, she could have been patient zero.
What can we hear more about this testing?
Yeah, so she just says it's kind of, sounds like it's pleuritic in nature, kind of going with what her cough she says. You know, she says she'll have this bout of cough. For the most part, it'll be dry, but then all of a sudden, if she coughs hard enough and long enough, she'll have this bout of like a puddle of blood coming out, which is why her doctor came out, which is why her PCP said get to the hospital.
Where is she from?
She's from the U.S.
Has she had trouble recently?
No, why do you ask all that?
I don't know, some weird fungal infections or TB.
Yeah, good. Jason's kind of doing the same thing.
Did you ever use IV drugs?
No history of IV drug use.
How long have the puddles of blood been happening?
She says so that's a great question. She went to the hospital. When she went to the hospital before, she was having some blood in her sputum, and they said that was secondary to her pneumonia. Got treated with their cap coverage. Then it went away for a little bit, but the past kind of couple of weeks, it's been kind of been there persistently and a little bit worse.
Any like joint, skin changes?
No, why do you ask that?
Like vasculitis.
Yeah, good thought. Yeah, so, you're thinking about the classic vasculitis rash, which is a buzzword for me, because everybody says that. I don't think anybody actually knows what a classic vasculitis rash really looks like. But that's great. Good thoughts. So I'll just kind of go back. I'll start going at past medical history. I think we got a pretty good HPI for her, but past medical history, she does have a bout of endocarditis, stenosis, mitral valve replacement. She does have DVT-PE. She's got this questionable history of CHF as well as the CVA. Past surgical, she's only had her mitral valve replaced. She's a never smoker, 1 drink of alcohol a month, and no recreational drug use.
She's 35?
She's 35, yeah.
Do you know anything more about this? I'm like, any of it. I'm sorry.
Yeah, great. I know. What do you want to know about it?
Flying?
So what do you want to know? Yeah, that's great. That's perfect.
Culture negative or culture positive? Like.
Yeah, so they actually never grew anything from her blood cultures. Why do you ask that?
I don't know. Lupus.
Nice.
Were these for both?
So, great question. So you do some chart digging. Looks like she had a PICC line, and that's where she had a TBT there, but she was incidentally found to have like a PE whenever they did her CTPE study.
And then the CBA, was that abolished?
No, so she actually, is that a code pager? Gosh, 2 days in a row. I'm sorry.
Quality compression.
I know. Quality of compressions and shocking. Yep, they're really shocking. Well, as the code team exits right now, CVA, she said she was like, looks like she was diagnosed with that because they saw something on an MRI finding that she had before. No clear, like, she never came in with like focal weakness.
Do we know if that was, like, did the time course correlate with when you did endocarditis?
No, it was kind of like an incident,
separate.
totally separate, yeah. And Jason John's like doing some name dropping there and putting in litmus stacks, which is great, which I think is where Michelle was exactly going to, thinking about lupus. So good thought.
What kind of mitral valve does she have? And what is her anticoagulation?
Great question. So she is she's on she's got a bioprosthetic valve. She is actually now on anticoagulation right now because she had her mitral valve replaced a year prior. She's on a bioprosthetic valve, and because of her hemoptysis, they did a risk benefit, and they thought it was increased risk of her being on anticoagulation. So that's actually a really good point too. So we always think about anticoagulation for valve replacement, and like when do we need to be on, how long do we need to be on. And if you look at, because I've looked at up to date about this, and it actually is a little bit hard to completely understand. Mechanical valve is lifetime anticoagulation. That's a hard and fast rule. But somebody who's got a bioprosthetic valve, you have a little bit more leeway, and it's at least 6 months anticoagulation. Now, if it's an aortic valve, I think if it's a mitral valve, I think you're more likely to actually do lifetime anticoagulation than aortic valve. But yeah.
This is like a mechanical, you have a higher INR and everything too.
Yeah. And what's your INR goal usually with those?
2535.
Perfect. Good. Well, good. Yeah. So, anything else you guys want to know about her history?
Did she actually have heart failure or did you know? No, it's her most recent echo.
Yeah. So she had an echo. A month prior. It looks like she maybe has a little bit of some LVH, but not significant diastolic dysfunction. No like elevated pressures in her heart. It looks like, and her LVEF was great. Okay, why don't we go over her meds that she's taking right now? So currently she's on Coreg. I'll just say she's on Coreg, she's on Bumex, she's on albuterol inhaler, Flexeril, and Norco. Anything big from that, like change dose management, or?
And if she actually had a stroke,
Yeah, good.
It doesn't all add up.
Yeah, so, no, this is great. So, I think that's totally appropriate. And, I guess one of the things is, so if somebody doesn't come in with an acute CVA, and somebody doesn't come in with an acute CVA or TIA, right? Those people, they're going to be on lifelong aspirin. That's kind of a hard, fast rule. But what about these people who have, like, incidental findings and infarcts on their CT scan or MRIs? I think that's one that's a little bit less, somebody who's probably more aggressive and probably is taking the forefront, yeah, probably put this person on aspirin. But that's a really good point. All right. Let's go ahead and go over her physical exam. So, let me just pull up my, I'll share my screen so you guys can see it. Is there what?
Her family history relevant for any kind of stuff?
No family history of any kind of rheumatic disease. So this is her physical. So you see, for the most part, the only thing that's kind of pertinent is she's a little bit on the tachycardic. She's borderline tachycardic, a little tachypneic, and she's a little worse hypoxia, statting 94% on 45 liters. And then her other exam, like on the rest of her physical, it just looks like she's got decreased inspiratory effort and some weak wheezes, no crackles. Otherwise, the exam was not significantly non-focal. So I know you guys are going to get labs on this patient. What do you want? That's probably going to be done at the ED before you even get labs for her. Yeah. Probably chest x-ray is going to come back before your labs too. So this is her chest x-ray, and I'll see if I can get if an intern is comfortable reading this for me. Debbie, what do you see on there?
So rotation looks normal. I mean, it looks like, so you want me to just like point out what's abnormal? Or like
Yeah, whatever you want to, whatever you want to do. This is dealer's choice.
I guess I can see the
She does not have a shoulder fracture, I'll give you that.
Yeah. I mean, there's just like diffuse kind of infiltrates on the right, kind of worse in the base. I mean, like, they just, like, patchy. They look very patchy. Like, but there's some on the left, too, but it looks greater on the right. He looks like normal lung volume. I'm, like, completely, my brain is not functioning right now, but the angle, cost-spreading angle, I can see them on both sides. And then her heart, I think this is just, like, a one view, so it's probably maybe a little bit difficult to interpret, but looks like a pretty, I mean, slightly enlarged heart, but like normal to slightly enlarged.
Perfect. Okay, so that's great. And just like I'm going to push you a little bit harder on this guy. If you had to decide, you see those infiltrates. Where do you think those infiltrates are? Thinking
like lobe-wise.
Or like, is this like a alveolar infiltrative disease, or is this a reticular interstitial infiltrative disease?
That looks more like alveolar.
Yeah, perfect. No, that's totally right. It looks like probably more like an alveolar infiltrative disease. So usually, like, you'll see this kind of reticular pattern, like her interstitial. You'll see like the lining of the interstitium a lot more. It'll be a lot more prominent than kind of just patchy, kind of some kind of filling process. So Danny always harps on this, and I think this is a great time to bring it up. So when you think about what's in an alveolar filling process, you got to think about what's in the alveoli. So kind of getting to like the basics, kind of like what content, not necessarily what disease, but like what content is in the alveoli. What do you guys kind of think about whenever you see an alveolar filling process? Perfect. And there's anything else? Protein, yeah. Yep. And then, yeah, protein cells, and then like if you want to get like even farther, like lipids and some other stuff. Yeah, calcium. There you go. Nice. So perfect. Yeah. So you see an X-ray like this, your mind should be going into which one of these predominantly three things is this going to be? And based on your history from her, what are you guys thinking?
Blood, G, or blood.
Yeah, perfect. So blood or pus is probably the big thing that I would think about too. So kind of as just kind of a little bit of, Debbie, I should have kind of asked you this too. Can you see anything else like that is not in her lungs per se? Anything else that is on the chest x-ray is kind of is a little bit hard to see here, but something that is maybe machinery or not natural to the body. Let me turn off the lights, so I think it's hard to see. Anybody else can call it out if they see it? Yeah. So so that's why you can actually see her biopsy valve right there. And then what's that in the middle of her chest? Yeah. So whenever you see those, you should automatically think this person has a thoracostomy. this person had their chest open for either valve replacement, cabbage, whatever that might be. Perfect. So when you guys hear about, I'm hearing a lot of people saying they think it's blood, could be pus, but let's just talk about if this is blood. What do you think of when you hear somebody's got blood in there? You're thinking about somebody's got blood in their alveoli. So first off, kind of, what do you label that if it's kind of all throughout their lungs? Which if it is, it'd be probably in it. Yeah. And so how do you kind of break down pH in your mind, like when you're thinking about what causes it?
Hemorrhage, capillaritis,
Wait, so maybe I can't hear that.
so like a bland hemorrhage or like a capillaritis, I would say that wrong.
No, that's right.
Yeah.
No, perfect, yeah. So our esteemed program director actually has a pretty fantastic way of remembering, and just kind of, so you don't kind of miss the causes of hemoptysis and somebody who's coming, or in hemoptysis and DAH. So he says his three categories start with, number one, neovascularization. And what do you guys think would go into that category? Cancer, yeah, cancer. What about if this person, say, was from some say they were from Mexico, yeah. No, TB, yeah. So cavitary lesion. And then aspergillus, and then also vasculitis actually goes under this category too.
Exactly, it's not just like new vascular function.
Yeah.
What does that word mean?
Yeah, no, that's perfect, yeah. Hey, this is why we do this. So the reason, like, there's like a couple reasons why like cancers bleed, but a lot of times is they're actually stimulating new vascular growth, right? Whenever you have rapid vessels growth, you remember they're not at all like structurally sound, they're very fragile. And so like these patients that get diabetic retinopathy, the reason that they actually get these like vitreal hemorrhages is because these new vessels are not stable, and so they bleed really easily. But cancer does the same thing. Cancer actually, because the more vessels that come to the cancer, the more nutrients it's going to get. And so they're stimulating new vascular growth to come to it. And those new vessels are going to be weak and unstable, so they're going to bleed really easily. Sorry. Yeah.
I
So,
think we had the exact.
no, yeah, exactly. Yeah. So cavitary lesions do like the same thing too, apparently. Any other questions about that?
Like diffuse cavitary lesions?
Well, usually, I mean, like even just one cavitary lesion itself.
Causes diffuse neovascularization as well.
So it causes.
Yeah, so if you've got a cavity that's slowly enlarging and you've destroyed the vessels around it, you're going to have aberrant vessels forming to work their way around the cavity.
So that calls it diffuse alveolar hemorrhage?
It won't cause. I should clarify. This is for hemoptysis,
Oh,
not
no,
DAH.
no,
Yeah.
thank you.
Yeah, that was my fault.
No.
No, that was a poor delivery. So after neovascularization, the next big category is inflamed tissue. If you guys had to think about what that's inflamed tissue would cause somebody to have hemoptysis. Not pulmonary edema per se. And this is like for actual like frank hemoptysis, somebody's coughing up blood, not like the pink frothy stuff you get from. See somebody's chatting up.
Pneumonia.
Yeah, so pneumonia, great. And then.
Just like any inflammatory process, so like autoimmune.
Yeah, and that's actually perfect. Yeah, autoimmune, and then kind of going along with any kind of inflammatory process, bronchitis will do the same thing. So most causes of hemoptysis are going to be bronchitis, which is far in between going to be viral bronchitis. This lady with her X-ray, the likelihood of her having a viral bronchitis is slim to none, and it looks like Slim just left town. So I love that line. So the only other category that is kind of going with hemoptysis is pseudohemoptysis. And so what do you guys think about for that? Like, when do you think, oh, this isn't really hemoptysis? What could cause that? Yeah.
Probably other blood in the oral.
Yeah. Yeah, so any kind of like upper airway bleeding or any kind of like GI bleed that somehow like makes its way into the lung and gets thrown up or whatever. So perfect. Good. So this is her chest X-ray you get. And then here are her labs. Anything in here striking to y'all or?
CRP.
What about the CRP?
It's pretty high. Panic was an inflammatory process, and what comes up to can't say whether it's like infectious or autoimmune, but then her procal's not like super high, so it's more like autoimmune connective tissue disease.
Yeah, that's really good. That's perfectly put. And just for like a clarification, the CRP is actually kind of a tougher one to interpret, like from like case to case, because CRPs are like kind of dependent on how whatever your threshold is at your hospital, and so a normal CRP here at our hospital is actually 10 and not like 2 at other hospitals. Yeah. Good. Perfect. Yeah. Somebody actually commented, yeah, her BUN is pretty high, which is good, a really good point. So outside of an AKI, kind of going with elevated BUNs, what do you guys typically think causes a BUN outside of somebody's got AKI? GI bleed. There's one other one I usually think about. What do you guys think? Yeah, perfect. That's one that not many people actually get, but steroids can cause you to have a falsely elevated BUN. Perfect. Anybody have any questions so far through this case? So, Dan, you mind like flipping over and I'm going to stop sharing my screen. So, you've got this patient, you're worried about DAH. What labs are you going to order for her that you already, probably like what labs do you want to order for her at this moment when you see that imaging? Kind of thinking about our causes of DAH. What do you guys think?
There's enough weird stuff that like I would go with the real things, so like complements and NA.
Complements NA, good.
If we want to check for like GBM and
Perfect, good, yeah. And what are you looking for with complements and ANA? I'll start with you first, Michelle.
So like lupus.
Yeah, good. Yeah, totally. I think that's perfect. And Davon, what about you? What are you thinking about?
Yeah, so like if complements are low, you kind of have an active flare. Actually, if you're I always mix up the two, but microscopic polyangiitis is like more kidney predominant, like lung. GPA is going to be more lung predominant. So GPA is one of the vasculitis that would cause this picture. Anti-GBM disease would also do the same thing. Capillaritis, basically.
Perfect. Yeah. So thinking about all like the pulm room stuff that are going to be causing you to have actually have a DAH. So you were kind of talking about too, like MPA, GPA causing renal involvement. Her kidney function is normal. Does that mean she doesn't have renal involvement of?
No, because
If she has a vasculitis?
could have proteinuria or something, or hematuria, something, or like also the creatinine of 1. Like I don't know what her baseline is.
So what would you probably what would you want to do with her workup of DAH?
Oh yeah. So I would get a urine protein creatinine ratio, and then also just do a complete UA, check the blood.
I also do like HIV, probably.
Nice. And what are you getting at with that?
Oh, just like kind of workup for infection.
Yeah, no, I think it's perfect. One of the things I think like that was kind of taught to me by Dr. Madinger is like young people don't get pneumonias. So if somebody gets a pneumonia, a young person getting a pneumonia is a rare thing. And so you should, if somebody is under 35 is having a pneumonia, thinking about immunosuppressive things like HIV, or if this guy's an IV drug user, poorly controlled diabetics, something's not right for them to get a pneumonia at a young age. So good. So, you order all those labs, you get the chest x-ray. Who are you gonna call in addition to getting these labs?
I would love to bronch this woman.
Oh.
Going on, so, pulmonology colleagues.
Nice. All right. I love this game. All right, Michelle. I'm the pulmonology fellow, and I want you to call me this consult and tell me what you would say when you're calling me.
I have a super weird case for you.
Whoa, I just woke up, Michelle.
Buckle up, because your scope is something today, very NCO, 30-something, is coming in, she's got a terrible chest x-ray, she has weird pneumonia, she's got an elevated white count, and she's thinking of VAH, and it's serial massage, and cultures, that, we have to save her.
All right, fine. All right, I'll come in. So,
You're a phone bill, you're super excited for a
It's early in the year still.
Yeah.
I know. I'm ready for that 3 a.m. bronch. So, labs are still pending, so I will share my screen and show you, what the, bronch showed. I'll see what you guys can kind of tell me what y'all think about it.
I have a question. I
Yeah.
feel like I generally find bronch when I think about getting a CT chest. So there's kind of confused, like, would that be useful here? Or, like, are there times when you could just go ahead and not get a CT chest?
That's a great question. My general thought is if this patient if you think they have DAH, you probably, and you have high enough suspicion, you have x-ray findings, you probably don't need a CT chest. But as a budding pulmonologist, I'll defer to Dr. Gergen on this.
I think, yeah, from a logistics perspective, I don't think you're gonna get out of consult for a person who has that chest x-ray without getting a CT. And right, if you're thinking about your alveolar zone process differential, the CT is probably helpful, because like, we had a case a couple months ago where someone had like pulmonary alveolar proteinosis. So you got the CT and they got some classic, like mosaic finding or crazy paving finding that probably changes the person within pulm or the true most toxic. But I think you're probably better off getting a CT if they're stable, just to make sure that it's not a disease-specific pattern.
So she actually they went straight to the the bronch and BAL for her. And what do you guys see as the kind of interesting thing with BAL procedure? Yeah. Perfect. No, that's it. So that's classically like the classic story that you get with DAH is they'll be bronching these patients, they lavage them, they keep getting more blood out when they keep lavaging them. Danny, is that right, or am I missing something on that?
No, that's correct. So the reason you get that is when you put the BAL fluid in the saline, essentially you get to the very end of the capillaries, and oftentimes you get a little bit of blood back when you do that. There's old blood there, washes back. But if you're washing out within the capillaries, and then the capillaries are filling with blood again, you'll keep getting blood on subsequent aliquots. So that's why the sort of progressively more bloody, we're staying the same amount of bloody is DH or alveolar hemorrhage.
So kind of going with, say this person's coming in with DAH, right? Or let's just say they're coming in with frankomoptosis. Let's say we can actually localize it to one side. And say this person all of a sudden is just coughing pretty vehemently blood and they're becoming worsening respiratory distress. What can you do to kind of, in that acute setting with this person who's struggling, before they come in to like bronch them, what can you do to help this person out with respiratory distress? And well, even before the intubating team comes in, what are you going to do? What can you do to help this person in the kind of immediate setting? So say all their bleeding's coming from their left side.
Oh, they position them.
Yeah, so what are you going to do? You put them on their left or their right side?
One side.
Yeah. Yeah, and why is that?
Can you actually, I have heard both things depending on which pulmonologist you talk to, both have hypotheses behind it, and then we did a huge list search of the VA, nobody could find an actual answer that was consistent.
That's fair. So because in my mind, from what we've learned about physiology-wise, when things are dependent, there's going to be increased blood flow to that area. And so my thought was you lay it on the opposite side. If it was bleeding on the left, you lay them on the right side. But it is the bleeding you lie down, and the reason why is because you want to prevent blood from flowing into the other lung field. So if they were up, it would be going into the right lung field, and then they would really become worse. They'd have worsening hypoxia. So in the acute setting, you put them on that left side, sacrifice that left lung, so you can preserve that right lung so you can still aerate.
And this is super confusing because this is the only time you put the disease lung down.
Only in bleeding.
Yeah, only in bleeding. If someone has a really bad unilateral pneumonia, you actually want to put the good lung down because you want preferential blood flow.
And then someone else did the exact opposite and gave the thought process that you did, and then so that research actually has no evidence that blood can trickle and blah, 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 blah.
It's all hypothetical. You need to
Yeah.
take something like bleeding lung down or healthy lung down in a large unilateral pneumonia.
Perfect. All right. So you get this PL. We think they got PAH, and lo and behold, their labs come back. All right, let me get down. Make sure I don't go forward. So what do you guys think now? And what would you want to do? AA comes back negative too. Gotta put that on there. Yeah. Yeah, good. That's a good point. So what are you going to do? So you got the bronch, pathology from the bronch comes back. It just shows like acute inflammation. Then we'll look and see nothing like that.
Either HIV or same memory.
I would also culture, I don't know, run studies in the bronx, like I don't know if they can do it.
Yeah, so,
What's the culture?
no, good. That's a great thought. So HIV comes back negative, AFBs come back negative. Let's just say they did, they actually checked for PJP that comes back negative too. So far when they did gram stain on the fluid, nothing grew from that. So this is kind of hard, right? This is kind of not where we get stuck. And kind of go back at her labs. So you see her ESR and CRP are like, her CRP's up, but it's not significantly up. Vasculitis, these patients usually are like in the hundreds for like ESR and CRP. They don't have to be, but like classically, that's kind of the thought. I know Jason's been chiming in a lot. I don't know if you have any thoughts right now, Jason, what you would want to do.
What about TB and fungal serologies?
Yeah, so quant comes back negative, AFE stain comes back negative. So this is hard, right? This is kind of where we usually hopefully serologies kind of point us into the direction that we want to go, and we can go from there. So the saying that is like still, that is by far like one of the best things ever is tissue is the issue, and kind of go with Parisa was saying, what about a biopsy? So the next question is, who are you going to call for biopsy? Yeah, exactly. So I guess you got to do, if you're going to do a transbronchial. And I gotta tell you, Danny, I don't know, how often does pulmonary do like biopsies themselves?
They do, yeah, so for interventional pulmonology, you would do a transbronchial biopsy. So if you wanted like a split liver tissue, you could do that before CT surgery.
Yeah.
Surgical lung biopsy.
So they actually call it CT surgery to do a lung biopsy on the patient. So I will show you the op report, and this is what, so CT surgery does a fast, and this is their op report. And I gotta tell y'all, I don't know what a lot of that stuff means, but I see edematous and diffusely diseased lung, and that sounds bad. And does anybody know actually what happens with the VATS procedure? Because this is one I didn't know until I actually watched a video of it. It was a great learning point. Dr. Gergen, you know it better. You can describe it better than I could. I feel like be doing a disservice to.
So what they do is they make, it's a laparoscopic surgery. So they make small trocar holes, they put the trocars in, and then they intubate one lung and deflate the other lung. And then once they deflate the other lung, they then operate within the chest wall. So they now have room on the shrunken atelectatic lung. So it's single lumen intubation and ventilation. And then once they're done, they make sure the sutures and staple lines are intact. They pull their trocars out, close them up. Usually people need a chest tube for a day or two, and then they're typically good to go.
Yeah, so it's actually like a laparoscopic procedure, which is not something I quite understood. And it's like whenever we always have, you're going to have plenty of patients that get this done. It's good to understand like what's exactly happened. So they actually did a wedge biopsy of this patient, found these findings, and they get, oops, dang it. I thought I had the all right, so this is her pathology that, this is the pathology that you get, and then this is the serology that you ordered too. So what do you guys think is going on right now? Huh?
Antiphospholipid syndrome.
Yeah, so when you actually go back through her history, you can keep that up, Danny. This is kind of other things that you find out about her. She's got a history of multiple miscarriages, 1 second trimester and 2 first trimester. Kind of with what you were going with, Michelle, which great questions to ask is like, what's the story about their endocarditis? And like, what did they grow if they did grow anything? So her path from the heart valve as well as her blood cultures did not grow anything. And then you look back and she's got this history of CVA that was told because she had this old infarct on her MRI. So kind of just as I've actually got one of our esteemed room fellows who was going to give a quick talk. I wanted to just kind of give people a little bit of explanation of when you should kind of be more suspicious of APLS from miscarriages. And so what this was kind of the, I can't remember what the criteria is called exactly, but this is the kind of unified criteria. So you have multiple unexplained fetal deaths after 10 weeks, 1 or more preterm deliveries, secondary preeclampsia before 34 weeks, or 3 or more consecutive spontaneous pregnancy losses before 10 weeks gestation. You should really think about APLS. And the interesting thing about this patient is, what if she has APLS? Michelle, what do you think was the etiology for her endocarditis? No, what do you, I mean, what was the phrase that Jason said, I guess?
Oh, leave it talk.
Yeah. What were you saying, Claire?
You just put a fluid in.
Yeah, and so actually that actually happens from the antiphospholipid syndrome from the lupus. And so, so when you have APLS, right, you have APLS that's causing a, if she had a thrombus on her heart valve, what does that tell you about where she had a thrombus? Because this is a hard way to ask it. So she had an arterial thrombus, right? And so she needs to be on anticoagulation, right? So her having her heart valve replaced, she's got DAH. What do you do in that situation? So we started her, so she actually Jason pointed out, she actually got started on pulso steroids. She also got rituximab, which you usually don't do for APLS, but they did it in this case. And then in addition, she had to be put on anticoagulation because she has an arterial thrombus. And so they put her on a heparin drip to see how she tolerated, make sure she didn't have any major bleeding, because it'd be easy turn off, turn on. She did fine, so they sent her out on warfarin. So when she left, this was her x-ray 2 weeks later. Like next day.
Why did they choose warfarin?
Yeah, great question. I'll let Sonia kind of go into details about that. What were you saying, Claire?
I was just going to say, there's better data for warfarin than DOAC.
Yeah.
That's fine.
No, that's perfect. You hit the abridged version, which is fantastic. So this is her x-ray 2 weeks later. And then this is her x-ray 1 month later. So her history was pretty complicated, but she had recurrent bouts of coming in and out of the hospital because of having to be put on anticoagulation, having frank hemoptysis, having DAH, and I think it took her almost like a year at least, maybe even 2 years before she actually got stable from this whole thing. So I actually was going to turn this over now to Dr. Khatter to kind of give us some info on APLS.
Awesome. Thanks, Corey. Can you hear me okay? Awesome. And then I also have not played around much with Zoom, so let me know if this, well, I guess I have to share my screen first. So just let me know if it doesn't work. Share screen, desktop. How do we look?
Looks good.
You can see it. Okay, perfect. So, hey guys, my name's Sonia. I am one of the first year rheumatology fellows. With this like screen view, I can't see the chat. So just pipe in if you have questions, but I'll take us through the basics of APLS. So I'll start with the antibodies because I think these can be kind of confusing. But there are three big ones, and these are antibodies against phospholipid binding proteins, not phospholipids themselves. And these phospholipid binding proteins probably do have a physiologic role in clearing out apoptotic cells. But then when you develop the antibodies to them, that's when you get pathology. So we have three big ones: the anticardiolipin, the anti-beta-2 glycoprotein, and then the lupus anticoagulant is actually a three-step assay that I think can be a little bit important to know how it works. But basically the first step is you have a test of hemostasis. So that would be either the APTT or the Russell Viper venom test. So step one is showing that that's prolonged off the baseline. Step two is you mix it with patient plasma. Yes, patient plasma. And then if it does not, it should not correct, right? Because then you're demonstrating that it's not a factor deficiency. But then the third step is when you add phospholipid to it, that test will shorten or correct, showing that it was a phospholipid issue. So those are your three tests for APLS. You should demonstrate that they're positive at least 12 weeks apart. That part can be a little bit tricky because you can get false positives during an infection or if you're on anticoagulation. So we do recommend testing it off of it or testing it outside of like a big septic event. And then you can get false positives or false negatives during acute thrombosis or in CAPS or catastrophic APS, which can make that part hard. I think one of the questions that has come up to me a few times in fellowship is which autoantibodies you should order. And that does matter because the IgG and the IgM mean a little bit more than the IgA. Of course, if you're very suspicious, then order the IgA. But if you are ordering this on someone inpatient, just get the IgM and the IgG first. And then obviously the more antibodies you have, the more that it's, the better, like the more it lends support to APLS. So I think these are the criteria that Corey was getting at. They're called the Sapporo criteria, and they're what we use to sort of diagnose APLS. So you have the lab criteria here, which we went through. I think the other question that comes up is if you have like a low titer cardiolipin or beta-2, what do you do with that? Usually a positive is like a high, or like a clinically significant one is high titer, so greater than 40 or greater than like the 99th percentile. But again, it depends on what's in front of you. And then your clinical criteria are thrombosis or pregnancy-related morbidity. Clots can be arterial, venous, small vessel. We can usually use imaging to help sort of evaluate how much clot burden you have. And then pathology like histopath can also be helpful because some of the skin findings or the renal findings can, at sort of the macro view, look very similar to other rheumatologic diseases, but then the pathology will show things that are a bit more specific to APLS. And then Corey went through the pregnancy one, so I won't belabor on that too much. But definitive APS is when you have one lab criteria and one clinical criteria. So you should have that pair. And then clinical manifestations, just to expand on this a little bit. So vascular occlusion or thrombosis is the big one. Venous clots can look very much like DVTs, but also think about it with clots in unusual locations. So Budd-Chiari, sagittal sinus clots, upper extremity thromboses, and then arterial. I'd say stroke is probably the most common. And then for like this patient, you can have a lot of extra criteria manifestations, and they don't get you necessarily points, but if you have enough of them, it would be useful to think of APS. So hematologic is most often thrombocytopenia. You can get an atypical TTP picture with this one. We don't have the ADAM TS13, but still like a TTP picture. Cardiac can be veggies, can be valve issues like the Liebman Sachs. Pulmonary DAH, but pulmonary hypertension and so I think that's the other big one. And then DAH, yeah, those are the big ones for pulm, cutaneous, like livido, sort of gangrenous type changes. This was actually on my medicine boards. You can get bilateral adrenal vein thrombosis, and that can lead to adrenal insufficiency. Pretty much any organ system can be affected in APS. And then I think I saw Jason refer to CAPS in the little chat box, or catastrophic APS. This is, it sounds like that's sort of what this patient was thought of and what they started to treat her with. This is a really, really rare, but just very horrible, life-threatening complication of APS. And it's not an insignificant chunk. I think it's somewhere upwards of 40% of people who have APS will unfortunately present with CAPS the first time that they manifest. So rare, abrupt, life-threatening thromboses in multiple distributions. The criteria that we use are listed here. So involvement of 3 or more organs, development of manifestations, either simultaneously or within a week of each other, confirmation by histopath, and then confirmation of your antibodies on at least 2 occasions. Definitive or definite CAPS is when you meet all 4 of those, but I think you can understand how that would be pretty difficult, and they're kind of stringent criteria. So then there's also an entity called probable CAPS, which is just a variation on those, like maybe you meet all 4 criteria, but manifestations happened within like 3 weeks of each other, or maybe you only have the antibodies positive on 1 occasion. It is important to consider the differential for CAPS because it can look like a lot of things. DIC, you know, you've got just intense activation of your coagulation cascade, of fibrinolysis. The labs will look very similar to CAPS, but that is more often due to a big insult, which you'll probably have clinical clues towards. HIT can look like CAPS, kind of. The heparin-induced antibodies can eventually lead to arterial and venous thromboses. TMA and MAHAs can look like CAPS, and that's also very hard because I just told you that you can get an atypical TTP in CAPS as well. So it's a diagnostic challenge. And then HELP can look a lot like CAPS as well. And then as far as other diagnostic challenges, like I talked about, those antibodies can be very tricky. And unfortunately, because of the sort of consumptive process associated with CAPS, they might be negative when you check it then. So you do have to have some sort of index of suspicion. And then as far as treatment for CAPS, it's very much the kitchen sink, which it sounds like what this patient got. There's not great data for any one good regimen. So we throw steroids, IVIG, Plex. I think Corey had mentioned rituximab, and then obviously anticoagulation, which can be tricky if you are bleeding into your or otherwise. So treatment for APS, just in general, if you are asymptomatic, if you've never had a clot and you have positive antibodies, you don't need to be treated. There is a group of people that we will call high risk because they are triple antibody positive and maybe have very high titers. Some people will put them on an aspirin, but I've also seen other providers just say that we'll wait for something to happen. A venous or an arterial clot will buy you warfarin with a goal of 2.5 to 3. And then if you're clotting through that, I think someone mentioned the data for DOACs isn't great. So then we have to get into the risk benefit conversation of upping your warfarin, your INR threshold, which a lot of people will do, just knowing that obviously 4 is getting a smidge up there, but yeah, what else are you gonna do if they're clotting still? In pregnancy, if it's your first pregnancy or you've only had one pregnancy loss at less than 10 weeks, that doesn't buy you any treatment. If you have had at least one fetal or 3 pre-embryonic losses, that'll get you prophylactic dose heparin plus aspirin. And we recommend treating that through 6 to 12 weeks postpartum. And then if you've had a clot before, obviously you have bought yourself anticoagulation, we just switch that over to heparin instead of warfarin while you're pregnant. And CAPS, we talked about, you do everything. The TRAPS trial is what was sort of briefly referred to, trial of rivaroxaban in antiphospholipid antibody syndrome, came out in Blood in 2018, asked the question, for high-risk patients with APS and a history of clot, is rivaroxaban non-inferior to warfarin for the prevention of like thromboembolic events, major bleeding, and vascular mortality? So they took these high-risk patients, which was triple antibody positive, and they had to have had a history of clot, but I don't think it mattered if it was arterial or venous. Randomized them to Xarelto or warfarin, and then the study was actually stopped, or it was stopped early because people on rivaroxaban were just having so many events. So we don't use, the bottom line is we don't really use DOACs in high risk APS. A lot of people have brought up the question, well, what does that mean for sort of low risk patients? What if they have one antibody, they've never had a history of clot? Well, I guess they've never had a history of clot, that buys you something else. But if they're low risk, can you still use a DOAC? And the answer is we don't know. So hopefully that is something that is being looked at a little bit more. And then other therapies, just to get a little bit into it, for the rituximab, it is really good. And again, we'll throw it at people who've had CAPS. We don't know if it's actually helpful with the thrombosis aspect of it, but we think that maybe it helps with thrombocytopenia and the hemolytic anemia. So if it's posing a problem, that could be an option. Statins, we know, sort of downregulate the pro-inflammatory and pro-thrombotic pathways. So we think maybe that helps with APLA-induced thrombosis as well. I feel like as internists, we always say that statins should be in the water, so it probably can't hurt. Plaquenil for secondary APS, particularly like as far as lupus goes, that is an almost widely agreed upon recommendation that those patients should be on Plaquenil because it's shown to be protective. And then complement inhibition is kind of the new kid on the block. We know complement activation is really important to the pathogenesis of primary and secondary APS. So I think it's I always mispronounce it, eculizumab. It's an anti-C5 monoclonal antibody. So I think that is something that we also have to look forward to for treatment. And that's all I got. Any questions about any of this? I don't know how to stop sharing my screen.
Yeah, I'll get it, Sonia. I'll get stop it.
Thank you.
Well, Dr. Khatter, thank you so much for being here and answering or giving this presentation and really giving us some good information on APLS. So thank you so much.
Thanks for having me.